Hi. Happy Monday, everyone. Welcome to our CCRN review. We're doing a quick rapid 30 today on multi-system concepts. If it's your first time here, I'm just going to introduce myself really quickly. My name's Rebecca Coulter. I am an ICU nurse. I love teaching and love helping nurses get certified, CCRN certified. A little bit about the CCRN. Again, in case you're new here and you just are wondering about it or you're joining on our Facebook or YouTube pages that also go to an NCLEX crowd. This is a webinar for a different exam. This is for experienced ICU nurses who want to get their CCRN. The CCRN is a certification exam that you can take after 1,750 hours of experience in an ICU, which usually takes about a year to acquire if you're working full time. And you'll sit for this exam after you get that experience, and it'll test your critical care knowledge. There's lots of really good reasons out there to become certified. If you're interested in going back to school for CRNA or nurse practitioner or any of that, those programs typically require CCRN certification. And then also, if you're just looking to learn some more information about your day-to-day job, gain some confidence at the bedside, preparing for your CCRN, and then obtaining that certification, it's a really good way to do that. So, here at Archer Review, we have a product for CCRN, which we're really excited about. It's been out for a couple months now, and it seems to be working pretty well for people. We're getting some feedback now that people are passing their exams and with using our course and QBank, and it's been effective for them. So we're really, really excited. We're also continuing to do weekly webinars. Some are short webinars like this one today, only about 30 minutes. Others are longer and offer continuing education credit where you can get a certificate for being present for those longer webinars. We've got one of those coming up a week from today. So stay tuned till the end to get a link to sign up for that webinar, and hopefully we'll see you there. Okay, that's my little spiel. It looks like we've got somebody here from Ethiopia who is an emergency and critical care nurse. That's awesome. I love when we get some international learners with us. Where is everyone else from? If you're here, just throw something in the chat. Tell me where you are in your nursing career. Are you preparing for the CCRN actively right now, or are you just trying to gain some new information, go through some practice questions, more just for fun? Where is everyone at in their nursing journey? It's one of my favorite things to hear about. Oh, Shakira, yeah, I remember you. ICU nurse in Atlanta, been an RN for 16 years. Oh my gosh. Sarah, working on CCRN from Doha. Awesome. Okay, great. I'm glad to have some familiar names back in the chat. That's perfect. ICU nurse working in Dubai. Amazing. Or Dhabi, I'm sorry, Abu Dhabi. I just read that really quickly and completely messed that up. United Arab Emirates. Awesome. Lots of international learners today. That's great. Okay, cool. I like to just get a feel for who's in the chat. ICU nurse from Scranton, Pennsylvania. Starting to study for the CCRN will be 2 years in August. Awesome. That's a perfect time to take the CCRN. I recommend, as early on in your career as you can, go ahead and start preparing for it because it will really make a difference in closing the loop on what you're seeing day to day at the bedside. When you start to study for this exam, you start to learn more. I mean, I waited quite a while to take my CCRN. I didn't work at a hospital that reimbursed us for it. And so I was like, oh, what's the point? I don't want to take it. And eventually I did. And I just thought, oh my gosh, I can't believe I've been, an ICU nurse, I think at that time for 3 or 4 years, and I didn't know this. But because of the act of studying for the CCRN, I was able to, close those gaps a little bit, which was really, really helpful. So I hope that that is happening for all of y'all too. We've got a couple from Florida, ER to ICU now. What a transition. That's awesome. I bet you are bringing a very good, unique experience to your ICU, and your team members, your coworkers are probably very thankful for the insight you can provide from having worked in the ER. 9 years work experience in a medical ICU. Okay, awesome. We've got some really great experience here. So like I said, today we're going to go through practice questions that relate to the multi-system section of the exam. The multi-system section, let me pull this up to make sure I don't get this number right or number wrong, is 14% of the CCRN exam. And it includes a lot of different topics. It includes really anything that doesn't fit well into another system. So things like shock states that affect the whole body in multiple systems, ABGs, we know that those relate to our respiratory system and our kidneys and how they compensate. So that's a multi-system problem. End of life, targeted temperature management, MODS, multi-organ dysfunction syndrome. Obviously, it's going to be a multi-system problem. And then trauma is another good multi-system problem. You'll see other topics on the test plan like maternal complications, bariatric complications, pain management, post-intensive care syndrome, a lot of just, again, it's just a catch-all, and it is a pretty good portion of the exam with that 14%. So we are going to spend the next little bit going through some practice questions and seeing how we feel about these concepts. It's a good amount of shock questions. That's a lot of multi-system, some trauma, etc. We'll get into a couple different things. So let's go ahead and get started. Feel free to continue using the chat just as you have been to communicate with me what your answer choices are for these practice questions. It helps me know where we might have a knowledge gap so that I can expand on why the right answer is the right answer. So feel free to throw your answers in the chat. It's a no judgment zone, obviously. These are difficult questions. I understand that completely. So just give me your best guess, and we'll learn together. Okay, so here's question number one. A 72-year-old patient with a history of COPD and chronic kidney disease presents in septic shock secondary to pneumonia. He is currently on norepinephrine at 12 micrograms per minute. ABGs show a pH of 7.29, lactate is 4.8 millimoles, MAP is 66, and urine output is now 8 milliliters an hour. What is the most appropriate next intervention? What do we think? Okay, we're getting a couple different answers in. Give it just a couple more minutes. Thank you guys for putting your answers in. That way we can talk about it. Okay, let's go ahead and talk about it. So the answer to this question is B, which I actually don't think came through in the answer choices. So if you got it wrong, you're not alone. This is a tricky question because we could do any of these interventions for this patient, but there is a reason that we're going to try B first. So first of all, let's just take this answer choice by answer choice since I saw a bit of a variety. So with A, titrate norepinephrine to maintain MAP over 70. Now, typically we know that we have a MAP goal of 65, right? That's our most common MAP goal. Occasionally we'll increase that, especially for brain perfusion would be a big reason that we might want somebody to be a little bit higher. So with our elderly patients, we sometimes want them to have a little bit of a higher MAP if we're on vasopressor therapy. In this case, we would maybe just have a higher goal because even though our MAP is sufficient, we're seeing that we're still not perfusing great. We have low urine output telling us our kidneys aren't getting great blood flow, and we still have a lactic count. Can someone tell me, it's kind of a long answer, but can someone tell me where does lactic acid come from? What does it tell us when it's elevated? What type of metabolism is going on? Yeah, great job. Mona Lisa. That's such a pretty name. Yeah, it's anaerobic, right? So if we've got a lactic acid count, we know that we've got tissues that are not getting enough oxygen. And if we've got a lactic acid that's high, we likely have a pH that's acidotic, which we are seeing here. So we might be motivated to give this person a little bit more blood pressure here and increase that MAP goal. However, we're on a pretty decent dose of norepinephrine. Now, we can do norepinephrine dosing in a couple different ways. This is written in mics per minute. I'd probably say that mics per kilogram per minute is more common, but this is a pretty decent dose. If we're on 12 mics per minute, that probably, we can't know for sure, but that probably relates to about around zero point 0.4, zero point 0.5 micrograms per kilogram per minute. So that's a pretty good dose. At that point, if we're still seeing that we're not perfusing tissues enough, we might want to add on a second agent. And that's why B is the answer. We're going to add vasopressin to support vasoconstriction, and it usually works to help augment that norepinephrine and make it work even better. We're not getting something from our norepinephrine that we need, and it's time to add on that second agent. Now, we got a lot of answers saying C and D, so I want to walk through why those are not correct either. So first, starting here with C, administer sodium bicarbonate for acidosis. I totally see where you're coming from. We have an acidosis present here. It is a lactic acid problem, meaning it's metabolic. If we were to draw an ABG on this patient, they would likely have a really low sodium bicarb level. However, we know that the problem here is perfusion. Even though our map is okay, something else is going on where organs are not getting enough perfusion despite that map. We need to increase perfusion and fix the problem versus using a band-aid like sodium bicarb. We actually try to avoid sodium bicarb as much as we can because it doesn't really help our patients out and it can actually hurt them. So until this acidosis is really extreme, like below 7, and we're trying to just really get that pH better while we're fixing the cause of all their problems, we're going to try to avoid sodium bicarb. So we likely won't give it for a pH around 7.29. It's just not low enough yet. Now, the next one here, begin continuous renal replacement therapy. We could do this. We're seeing acidosis and we're seeing oliguria, which are two indications for CRT. However, again, it seems like our problem is perfusion. We don't have tissues getting enough oxygen, evidenced by this lactate. So before we think about CRT, we're going to try to get those kidneys some more perfusion and see if that increases their function. We're not going to jump right to renal replacement therapy yet when we're only on one pressor and we still are showing too many signs of this lactic acidosis. If we had this lactic recover that got lower, showing us we're no longer in that anaerobic metabolism, we're below 2 for our lactic acid, but our pH continued to fall and those kidneys didn't bounce back and make more sodium bicarb and our urine output didn't improve, then we're thinking, okay, now we are in aerobic metabolism. We don't have a lactic acid anymore. Now our kidneys are just showing us that they probably have an AKI from this septic shock. So first thing we're going to do with this patient is add another pressor. And then we can start to think, does that improve our perfusion? If so, we can avoid C and D altogether. Thank you, Mona Lisa. I'm glad that that was helpful. Okay, perfect. Any questions there? Since I got a variety of answers, so it is a difficult question. Definitely let me know. Yeah, great question, Hannah. Hannah's asking, when using micrograms per minute, what is the average max dose? It's 30. 30 is the typical average max dose for micrograms per minute. So when I've worked at hospitals that do both, and when I first worked at a hospital that did it the different way, that's kind of how I get myself oriented. So if I know that the dose range for mics per minute is 1 to 30, if we're at 12, I'm thinking, okay, we're sitting around just under half our max dose. Whereas when I think about, I work at a facility now that has weight-based, and our dose range, at least at this facility, is 0.02 or 0.05 to 1 microgram per kilogram per minute. Then I think, what's the half max dose for that? It's around 0.5 mics per kilogram per minute. So that's kind of how I think about that in case you get a conversion that's different than what you use at your facility. Okay, great question. Let's move on to question number 2. This is a trauma question. So we have a trauma patient with a pelvic fracture, with pelvic fractures and femur fracture, who's been resuscitated with 3 liters of lactated ringers and 4 units of PRBCs. His labs show hemoglobin 8.2, our calcium 6.7. Ionized calcium 0.8 and fibrinogen is 120. Lots of different labs here. What complication is most likely contributing to his hypotension and prolonged QT on the ECG? What do we think? This is a tricky one too. Good. Seeing a variety of answers again, which is no problem. This is a tricky one. Okay. Got a few correct answers there. Very good job, everyone. And the people who didn't get it correct, I can tell you that person's probably experiencing what you put as well. But what kind of guided us with this question is really in the stem here of the question. What complication is most likely contributing to his hypotension and prolonged QT on the ECG? So that should tell us we've got something going on with electrolytes. Um, so we didn't get anything about a lactate level, anything about acidosis. So we can go ahead and knock A off. And I don't think anybody said A. So great job. The answer here is going to be B, which a lot of you put in. So great job. We are experiencing hypocalcemia from citrate toxicity. So we can see our serum calcium's low and that ionized calcium's really low. Um, what does, where does citrate come from? Why does this patient have citrate toxicity? Where's the relevance there? Because we didn't mention anything about citrate in the question, but there is something in the question that has citrate. Who can tell me what that is? It's not LR. Yeah. Yep, it is PRBCs. So when we have stored blood, that blood needs to have a preservative in it to keep everything good and keep things from clumping and clotting. And citrate is what is in blood in order to preserve it before it can be given to the patient. So when we give multiple units of PRBCs, 4 units definitely falls into that realm. When we get 4 units of PRBCs, we're thinking, oof, we need to check a calcium. I'm usually thinking about calcium at 3 units, thinking, okay, we've given quite a bit of blood here. We've got a lot of citrate on board. It's going to bind calcium in the blood and cause hypocalcemia. That hypocalcemia is going to cause hypotension and a prolonged QT on the ECG. Just um, natural causes of not having enough calcium. Calcium really does affect inotropy. And so that is going to cause our decreased blood pressure. Now, some people said C for hemodilution from crystalloid overload. We could be seeing that. With this type of trauma patient, it's likely that this hemoglobin is still low due to bleeding because we've had to give so much blood. And we've got a low fibrinogen telling us that active bleeding is occurring. We're losing clotting factors. And that definitely happens with bleeding. Somebody said, should FFP be given as well? Yes, FFP would be a great option, assuming that our other clotting factors are messed up. Now, fibrinogen, we give a very specific blood product to improve fibrinogen. Can anyone tell me what it is? What blood product do we give to increase fibrinogen? We've got plasma. Plasma does have a lot of clotting factors in it, but it's not going to help fibrinogen specifically. It's not to say it's not a good option. There's one that we give for fibrinogen specifically, and that's cryoprecipitate. We will give cryo to improve fibrinogen. Whereas if we were seeing a prolonged INR, that's telling us about certain clotting factors that plasma is really good for. And we've got another question kind of related to this, so we'll hit that again. So yes, hemodilution I'm not too worried about, and hyperkalemia is not usually associated with stored blood transfusion as much as hypocalcemia is. Hypocalcemia with stored blood, because of that citrate binding the calcium, is very, very common. Someone's asking how come it's B first is to treat acidosis, then need to add vasopressin in severe acidosis. I think that might have been for the last question. Um, Yeah, this, I see totally what you're saying. Acidosis really does affect the way that medications work. This pH is not severe enough of an acidosis to worry about that just yet. We'd still add on that other agent. Good question. Okay, perfect. A 58-year-old male post-operative sepsis patient has been intubated and sedated. His vitals are heart rate of 56, blood pressure 86 over 42, our CVP is 2, and SVR is 500. He is afebrile. Which type of shock is most consistent with this presentation? I'm seeing some answers come in. Really focus, based on some answers that I'm getting, really focus on our heart rate and our SVR. What type of shock has those particular numbers? This is a tricky question too. If we just had the hemodynamic profile, I think it would be easier, but we've got lots of other details in this question that can make it pretty difficult. Good job, Shakira. Zirahoon. Yeah, we're seeing lots of different answers. So let's go ahead and talk about this one. So we know that this person is septic, right? We've got a sepsis patient. So instantly you see that and you're probably thinking, well, likely they're going to have septic shock. And I don't blame you for that. We've got hypotension, which we know is characteristic of septic shock. Um, but our other numbers, our other hemodynamics really don't paint a good picture for septic shock. And that is our heart rate and our SVR. They're way too low. In septic shock, we have that massive vasodilation from all of that inflammation. And that's going to cause a couple different compensatory mechanisms. And that's going to be, well, actually, our SVR is okay. I got mixed up there in my head because we're seeing vasodilation. So our SVR is okay. But this heart rate is not right. We would typically see tachycardia to help increase blood pressure, increase cardiac output in the setting of that extreme vasodilation. CVP is fine. That with septic shock can kind of be all over the place. So yeah, this heart rate is our giveaway that something else is going on. We know that they're post-operative, and it even kind of helped us here in the answer choice. So our answer here is C. This person's in neurogenic shock due to spinal anesthesia, which is a thing. When somebody gets spinal anesthesia, they are at risk for neurogenic shock, at least temporarily, while some of that anesthesia wears off. When we're in neurogenic shock, we have a parasympathetic tone, no sympathetic nervous system. That's going to lead to that bradycardia and vasodilation that we see with this SVR. And the fact that it told us that the patient's afebrile would be another reason, oh, maybe this isn't septic shock. Okay, other answers that I think we saw. We saw cardiogenic shock. We don't really have a great reason to think it's cardiogenic shock. 56 is a low heart rate, but it's not low enough for like complete heart block, which would be an arrhythmia that would lead to cardiogenic shock. Obstructive shock from tamponade, nothing else is really telling us that. What number actually in our hemodynamic profile, which number would be much higher in obstructive shock from tamponade that you could use to rule that answer choice out? Would our heart rate be higher, blood pressure, CVP, or SVR? And there actually might be multiple answers to this one, but there's one I'm really looking for. So what I'm getting so far is SVR and heart rate. Absolutely, we might totally see that. Our CVP would also be significantly higher. If we are reducing that cardiac output so much, we are going to see that backup of blood flow and see a really high CVP with tamponade. So great job. Great job. Tough questions, I know. Oh my goodness. Definitely tough. Okay, this one I think is maybe a little bit easier. Okay, a patient with acute pancreatitis develops hypotension, altered mentation, a P to F ratio of 180, and oliguria. Labs reveal that we've got an elevated AST and ALT, creatinine of 2.5, baseline 0.8, and thrombocytopenia. Which syndrome is this person experiencing? Which syndrome is best represented? Good job, Hannah and Shakira, Mona Lisa. Yeah, you guys got it. Perfect. This one's, yeah, a little bit more straightforward. Um, great job. So yeah, the answer here is C. This is classic multi-organ dysfunction syndrome. We have somebody who comes in with one condition, pancreatitis, which is known to cause systemic inflammation, lots of inflammation on board for acute pancreatitis. And so SIRS isn't a horrible answer there. This patient likely is in some sort of SIRS response, but the best representation is going to be multi-organ dysfunction syndrome because the symptoms are really telling us we've got lots of organs involved that are dysfunctioning. And those labs are really huge. We've got elevated AST and ALT telling us our liver's upset. Creatinine is elevated, telling us our kidneys are upset. Thrombocytopenia can also relate to liver, kidneys. P to F ratio is respiratory. Altered mentation, we've got neuro, hypotension, cardiovascular. I mean, we've got lots of systems involved. Can someone tell me how many organs do we have to see in dysfunction to qualify for mods? How many organs does it take to say we've got multi-organ dysfunction? Great job. Absolutely. Just two or more. As soon as we've got two organs involved, we know that multiple organs are involved. What are some common causes for mods? Acute pancreatitis is definitely one. There's a few others that are really common. One big one that's really common. Common causes for mods. Sepsis is a good one. Yeah, absolutely, Shakira. Sepsis is probably the biggest one. And then any sort of trauma, burns are another reason. I've got some listed here. Primary mods would be that kidney failure. That can lead to, an isolated injury causing multi-organ dysfunction, whereas these other ones happen more secondarily due to inflammation, making sepsis such a big reason for them. Great job. All right, let's keep going here. Um, oh yeah, I like this question too. A 67-year-old woman is receiving vasopressor support for distributive shock. Which assessment finding would most reliably indicate improved end organ perfusion? This is kind of a difficult one too, but I think we'll get there and we'll make it make sense. Good job, Hannah. Good job, Mona Lisa. Good job, Carolina. Or Carolina? Carolina? I'm from North Carolina, so hopefully Carolina. Yeah, a lot of yeah, we're there. So we're seeing a little bit of variety in answers here. But a lot of you were on the same page. And this is a difficult question. So if you didn't get this one right, it's okay. But I hope with this explanation, you'll understand why C is the correct answer. So when we see this serum lactate decrease from 5.2 to 2.9. It's kind of like what we were talking about before. We are now having evidence that regardless of what our blood pressure looks like, our organs are truly getting enough oxygen that they do not need to operate in anaerobic metabolism anymore. So when this question, look at the stem of your question here. Which assessment finding would most reliably indicate improved end organ perfusion? So it didn't just say improved condition. It gave us a really specific thing to look at, which is that end organ perfusion. A map of 65 maintained for 2 hours is awesome. We would consider that a good perfusing number, but everyone's different. And depending on the oxygenation status of the patient, the cardiac output of the patient, that map of 65 might not actually be enough to provide adequate end organ perfusion. Heart rate trending downward is also a good thing. We know that heart rate typically compensates for lack of perfusion. So if we see that high heart rate start to come down, ideally that means that our blood pressure is improving. But again, it could be downtrending for a lot of different reasons. It's not specifically telling us that we have improved end organ perfusion. I'll skip down to D here. Temperature increasing from 97.2 to 98.6. This is slightly hypothermic. So that which we can see with septic shock, if that's the type of distributive shock that this person's in, we could see them have hypothermia, and seeing that improvement in temperature means their condition is probably improving. But again, it doesn't tell us about end organ perfusion, but our lactic improving does. It's the most specific outcome for what the question asked. And that is probably the biggest tip I can give you for the CCRN. Really look closely at exactly what the question is asking. The goal of the CCRN is not to trick you. It just wants to assess your critical thinking for addressing what interventions, what symptoms, what vital signs show what, like what's attached to what, and knowing that, in this case, lactate is attached to end organ perfusion, even more so than MAP is. So that's really a big tip I have for you is read these questions really carefully. When you get to the end of the question, really pay attention to what specifically is it looking for, because every single one of these answer choices tells us the client's condition is overall improving, or the patient's condition's improving. But this one is talking about the question, end organ perfusion. So really good job, everyone. Okay, I think I'm going to do one more. I know we're kind of short on time here, but I want to pick which one I want. Do I want this one? I think so, because this one we kind of talked about. So we should go into this one with a little bit more knowledge. A patient in DIC has mucosal bleeding, ecchymosis, and hematuria. Lab values include platelets at 42,000, INR 2.5, fibrinogen 110, and our D dimer is elevated. What is the most appropriate intervention at this time? Good job, Shakira. That was nice and fast. Same with you, Hannah. And Carolina, y'all are on it. Wait for a couple more answers. Okay. Yeah, I really just wanted to use this question to kind of revisit what we've already talked about. So the answer here is B. We're going to administer a platelet transfusion and cryoprecipitate. So we got lots of different coagulation numbers here. We've got low platelets. These are all very indicative of DIC. Low platelets, INR is 2.5, fibrinogen is 110, D dimer is elevated, blah, blah, blah. So platelets are going to help with our platelet number. I'm not even going to ask, right? Platelets, increase platelets. Cryo, we said this already, which specific coag factor that's listed is cryo going to improve? We already said it this lecture. Great job, Shakira. Yeah, and Hannah, fibrinogen, right? So fibrinogen is a specific clotting factor, and cryo has fibrinogen in it. So we see low fibrinogen, usually under 200 is when we're starting to think about giving some cryo. That varies, depending on what's going on with the patient. Oh, I just gave myself a thumbs up. Um, Depends on what's going on with the patient and your provider. But cryo for fibrinogen. INR, which blood product would we give to help improve our INR, assuming this is not a warfarin related issue, which in DIC it's probably not. What would we do for this INR? It's not in the answer choice, but we could absolutely justify giving it. Great job. Yeah, plasma or FFP. Plasma has lots of different clotting factors in it, and they're the ones that are measured with INR. INR, so your PT-INR versus your APTT are looking at different clotting cascades. So they're assessing different clotting factors. So we could see with an INR, that's why FFP is what we give for INR when it's prolonged. Now, obviously, if we think warfarin's part of the problem, that's when we would begin IV vitamin K therapy to reverse that warfarin. But we don't have any indication that this person was on warfarin, and we know that the main deal here is DIC. DIC is characterized by massive clotting and massive bleeding because clotting factors get used up really, really quickly. When we've got clotting factors getting used up, that is going to show our serum clotting factors to be low. So a prolonged bleeding times evidenced by that INR and PTTT. I think that was an extra T. PTT. There we go. And fibrinogen will be low. D-dimer's elevated, indicating that there's clot degradation products in the bloodstream from lots of clots being present. Classic lab value profile for DIC here. Great job. I'm just going to keep going. So, if you have to hop off, feel free, but I'm just gonna keep going. Okay. A 59-year-old patient with cirrhosis and GI bleeding develops hypotension, tachycardia, and confusion. Which of the following hemodynamic profiles is expected in this scenario? If you've been on a webinar with me before, we do a lot of hemodynamic profiles, so you might come in with a little bit of an advantage. Good job. Okay, getting a couple different answers. I'm going to ask a follow-up question before I give the answer to this question. What type of shock do we think this patient is experiencing? It might not be fair to ask that just yet, but any guesses? Good job, Shakira. Yeah. So when we're looking at this, we've got somebody with cirrhosis, meaning they're not making clotting factors very well, so they're really prone for this GI bleeding. They're probably having massive GI bleeding. If we're having massive bleeding and getting to this hypotension, tachycardia, and confusion, that's classic hypovolemic shock. We are hypotensive, we're tachycardic to compensate for that hypotension, and confusion because we have a poor perfusion. So that's our symptom of poor perfusion. Now we can just look at what hemodynamic profile is consistent with hypovolemic shock. Now, we've got lots of compensatory mechanisms happening with hypovolemic shock. So our answer here is going to be, we're going to see increased SVR as we don't have as much volume in the tank. So the body's going to try to clamp down the tank and make that volume go as far as it can. It's a great compensatory mechanism for hypovolemia. Decrease cardiac output because cardiac output is a liters per minute measurement. So anytime we've got less liters floating around in the body, our cardiac output's going to be decreased. Even if our heart function is completely fine, we will see a lower cardiac output. Decreased CVP is a volume measure. Our central venous pressure is a volume indicator. So if we're in hypovolemic shock, that is going to be decreased. So this is the only one that fits hypovolemia perfectly. And you know that you're in that hypovolemic shock based on the fact that we have a source of bleeding, that GI bleeding, and then we have these classic shock symptoms. So that's the other thing, another CCRN testing trick. As you're reading through these questions, they can be lengthy and have lots and lots of details. As you're reading through them, go ahead and start to try to categorize your patient, especially by the time you get to the last sentence that's usually asking the question. Try to think, okay, I'm thinking about a bleeding patient who with this set of symptoms is likely in hypovolemic shock. Now let me go in. Now I can see it's asking about what hemodynamic profile is expected. And I think through, okay, hypovolemic shock has this type of hemodynamic profile. And it makes sense. We're losing blood, so we're going to compensate with our SVR. Our cardiac output might not look as good, and our CVP is a volume indicator. It's going to be low because we don't have as much volume. So go ahead and think through those things. That's one of my main testing tricks is think through the answer of the question before you read an answer choice. That way you go in knowing what you know, and you'll be less likely to be distracted by other answer choices. For me, that is pretty much how I have to take every single test. Is just think about what I know and then read answer choices so that I don't get manipulated by what the answer choice says. Okay, great job today, everyone. I've got a QR code here to sign up for our next webinar. It's next week. We're going to do a renal system crash course, which I'm really excited about. This is a CE webinar. And what that means is that if you attend via Zoom on Zoom by signing up with the Zoom link here, then and you stick around for 80% of the webinar, you'll get sent a certificate with a contact hour attached to it. So if you need that for your licensure, or your hospital requires contact hours, or your certificate, once you become CCRN certified, they will require contact hours. You can use these certificates to help you reach those goals. So here's the QR code. I'm also going to throw the link just directly into the chat. Ideally, maybe. Let's see here. And this will just take you directly to the link to sign up for this webinar. It's completely free. So definitely take advantage of that. There it is. And I'm going to put it in the social media chats too. Because again, if you join not on Zoom, then I can't get you a certificate. Carolina, this webinar was fun, and you purchased the CCRN Archer review yesterday. Yay! Archer helped me pass your NCLEX years ago. Awesome. So excited. Yeah, we are trying to, Archer's growing a lot, and we want to support nurses for their entire lifespan. So definitely happy to have you here after your NCLEX. And you'll have to report back to us when you pass your CCRN and let us know how everything went. Very tricky questions, but extremely helpful. I'm glad it was helpful. I know that they're tricky. I do think I made them a little hard for today, but it just allows for more conversation about the conditions. Do you have to subscribe before you can sign up? No, you do have to have a profile with Archer Review, but you don't have to buy anything to sign up. So you don't have to subscribe to our CCRN course. You should just be able to make a profile with your name so that we've got a name to put on the certificate. Used Archer since before and shared with friends. We all passed our NCLEX and now we are taking up CCRN. That's so exciting. That was kind of the vision behind the CCRN product was, people are now, they might have used Archer for their NCLEX and then they want to take their CCRN and they can have an Archer product for that as well. Was watching one of your YouTube videos and went right to Archer to look into the program and was able to sign up just in time for this webinar. Hannah, that's so exciting. Thank you for seeing the YouTube videos. All of these webinars get posted to YouTube. So if you want to watch them again, they're on YouTube and they'll stay there forever. Okay, you're welcome, James. Thank you guys so much for coming. This was a really fun one today. We will see you a week from today.